Okay, we're going to get started. Please return. Good morning, everybody. Let's see. I want to know, put this here. Back row, can you hear me adequately? Okay, I'm getting a thumbs up. Good morning. My name is Stefan Kertész. I'm a faculty member in the Department of Medicine. I am an internal medicine doc and work a lot at the VA. I am charged with giving a kind of overview of the healthcare system, in quotes, because in certain ways it's not a system. And so a good chunk of this talk is meant to be factual, background facts, some of which you probably have seen in the readings. Additionally, I'm meant to be a little bit of a contrast in terms of points of emphasis from Dr. Huddle. You'll see how much our perspectives differ tomorrow when we have a more opinionated panel session, but still, just by choice of topic, there's a contrast here, because I'll focus a lot on the challenges of inadequate coverage. There are a number of disclosures. I put these up in part because they're sometimes expected, so I work for entities that receive money for providing health care, your tax dollars typically. My charitable work has been tied up with pharmaceuticals, and all of us who are getting medical education have wound up receiving federal support. And I say this in part because it turns out that healthcare and its industry essentially wraps itself around us every which way from the get-go. So we all have a very complicated relationship with healthcare. For this morning, the agenda is in part to give sort of major statistics on coverage and cost, channels by which people obtain coverage, an exploration of what we gain from it, what drives rising expenditures, although I will treat that to a lesser degree because I know so much of it came up in the first two lectures which I attended by Dr. Huddle. What happens when coverage is lacking, and can we expect that getting coverage makes it better, which obviously pertains a little bit to the Affordable Care Act, which I will touch on. So I have one of these interactive questions. What percentage of people in the USA are without health insurance? Do I have to click something? It says polling open. Okay, I'm doing all right. And how do I end the voting?
Well, when you look at the time will appear.
Okay. So I'm going to click and say...
Wait till, basically just look here. The total's going to be 170 to 180.
There are a lot of people here. Okay. This is a big class.
Yeah. So once the number gets in that, oops, so you clicked it.
I clicked too early, according to Tom.
I think
Is it going to be upset with me?
no, it's going to be fine.
Okay.
So once that goes off, now click it again and you'll get the result of the poll.
Okay, poll results. So split more or less between the two upper numbers. The 11 to 20% range is really the accurate one. Although if you ask what percentage of people lack health insurance for some time during the year, it's going to be roughly double, so it would be higher. What is the coverage situation of the non-elderly population? General people over 65, maybe it's 67 now, have Medicare, depending when they jump in. But the coverage situation is here for people in the U.S. Employer-sponsored insurance is dominant. Individuals who are uninsured are 18% of the non-elderly, obviously a lower percentage of all persons. Medicaid and other public programs are significant. And private non-group insurance, which I'm going to focus on in part later, is actually a pretty small proportion of the coverage situation. 48.6 million U.S. persons are uninsured. You're going to see an estimate about number of uninsured on the next slide, which is in the 50s, and that has to do with including illegal immigrants. 10% of kids are uninsured, and 22% of the uninsured in the U.S. as a whole are not U.S. citizens. Some of those are documented and some are not. What's going to happen in the future? These are updated projections from the Congressional Budget Office. So the way to look at this is to say, under prior law, it was estimated that there would be 57 million persons without insurance from 2013 to 2023. Not much changed. That does include the undocumented or the illegal immigrants. And then with the Affordable Care Act, the number would drop from 55 to 31. Although most of that drop is, again, in legal U.S. citizens. how do people get coverage? Well, a big component is employer-based insurance. 56%, as I mentioned, are covered by an employer policy. Family plans are fairly costly. The individual plan is also costly, but it's a lower number. But $12,000 to $15,000, the employee pays out of pre-tax dollars 20 to 35% of that. Probably an important thing to recognize is that there's really been a rush of employer movement to plans that involve a higher deductible, meaning the amount of money that the person has to pay before they receive payment coverage from the insurance plan, and just in the last 3 to 4 years. So now 19% of employees are in such a plan. Typically, those are defined as a out-of-pocket, a liability on the deductible side of about $2,500 or more. There's a federal definition, which is where the max out-of-pocket is $6,350 for a single adult, and for a family, more like $12,000. So those are really on the rise and are going to continue to increase even under the Affordable Care Act, or at least that's what people believe at this point, because it permits them, and it turns out that these plans can qualify as bronze plans under the Affordable Care Act, so they'll fit. So, poll. Does the federal government spend more money on Medicaid, military and veteran health care, or the tax break on employer-provided health insurance? I guess the word spending can be confusing if you give people a tax break. In this case, it's called a tax expenditure. Sorry, I should have hit the button earlier. Okay, wow, we're up to over 181. People voting twice? Just teasing. Okay, polling closed. Answers, Medicaid. And yes, that's true. The people who thought about the tax break are not terribly far off, because you're going to see it's very close. So what is the federal government's role? And I'm going to kind of go through some of the players who provide insurance, but with emphasis on Medicare and Medicaid. So Medicare covers principally elderly and disabled. Tom, I think you've given the material more on that, and some of our readings cover that. Medicaid covers some poor and the disabled. I'm going to focus quite a bit of attention on that. I've put the last appropriation figure for either 2012 or 2013 in the slide, just so you can get a sense of the scale of federal expenditure. Military and veterans care is obviously smaller, but substantial. Community health centers are a very small component, but important for a lot of the poor. Research is a big federal involvement in health care. $31 billion is quite a bit more than community health centers. There are mental health and substance abuse programs sponsored by the federal government. And this is just a selection. There is more than this. I didn't find a total figure for public health, infectious disease, but that's just to give you a sense. The other thing the federal government pays for is medical education, which is hard to parse out because a great deal of that cost is wrapped up in Medicare. It kind of comes through Medicare. Tax subsidies for employers, guesstimated, but it required a modeling study, that about $260 billion, which means it's a close, making insurance a pre-tax dollar expenditure means that it's almost as expensive as the entire Medicaid program. Just a brief comment on Medicare. Again, this is not meant to be exhaustive, but just a couple highlights. It's a combination of taxes, which themselves come from the Medicare Trust Fund, as well as general funds, and patients pay out of pocket, depending which part, A, B, and C, different amounts. It covers people who are over 65, people under 65, and disabled, and people with end-stage renal disease. And spending varies geographically in ways not explained by patient need or characteristics. The picture is really a depiction of the density of spending in different regions during the last 3 months of life or 6 months of life. I can't remember which. And, you know, there's these kinds of analyses have been done for a lot of different conditions, but there's relatively little reason to think that having much higher spending in the last 3 months of your life and much greater density of service really makes a wild difference compared to having less. So does the person in North Dakota, South Dakota, or the San Francisco Bay Area really have a much worse last 3 months from someone in Miami because they have roughly 65% as many dollars spent on them in that time frame? Probably not. So it's just a hint of variation. Yes? This is looking at people in Medicare. So it's, first of all, normalized, well, set to people who have Medicare, set to people who are in the last 3 months of life. This is not, I do not recall if this particular analysis is adjusted to the distribution of ages of people in the last 3 months of life. I guess if for instance, in one place, most people in the last 3 months have just been hit by a car and they're 22, you can imagine that the density of spending would be justifiably much higher to try to just save them no matter what. But I don't think there's a strong reason to think that's the case. And in other analyses of this sort, they do control for age and race and sex distributions, and you still find these fairly wide variations. Wow, that's a great comment. And you're going to see, this comes up with the non-Medicaid expansion states as well. When I'm feeling churlish, I think that. When people, the factors that drive the variation in geographic spending appear to involve a complex interplay of local custom and the availability of high-tech resources and hospital beds to be used, and the funders and the market power. So it's pretty complicated what it is. Beyond that, I don't think I can say, but I love to speculate about that stuff. Which group has not been traditionally covered by Medicaid? $177, that's the threshold to hit it. Okay. Okay, poll results. Everyone, well, most people did actually get this. It's poor single adults. Poor elderly can wind up covered, particularly if they've ran out of their assets and it winds up becoming a major payer for nursing home care. Poor parents, this is a little bit of a tricky one because there are provisions in many states where if you are a parent and you're poor and you have a kid, you can get into Medicaid. Some states did this by explicit expansion. They got a waiver. They expanded over the last 10, 15 years. Others will say, I think in Alabama, there's a poor parent program. If you make less than roughly $250 a month, $250 a month, you can actually get into that program. But obviously, it's very hard to survive on less than $250 a month. Poor kids traditionally are covered by Medicaid. But it's the single adults who would represent the target area of interest when we talk tomorrow, particularly about the Affordable Care Act. So some things on Medicaid. Again, just basic overview. 54 million Americans were enrolled in 2010. 42% of the poor, which means a lot of poor people are not enrolled. The way it's funded is through a match. So the federal government contributes a certain amount in proportion to the state's contribution, and the formula for that contribution, I think, was fixed in the 60s. I've never really checked exactly the year, but it's sort of a customary rate that reflects some original decision about what the states could do. So Massachusetts, it's going to be a 1-to-1 match. Alabama and a lot of historically poor states, it's a 2-to-1 match, or thereabouts. So it's a better deal in a sense for Alabama. Traditionally covers the groups mentioned, extremely poor parents, disabled, not low-income single adults in most states, but to be fair, in the last 10 years, many states did, at least a fair number, increased and adopted such a population, and then for those states that take on the Medicaid expansion under the Affordable Care Act, it will cover them. The Medicaid expansion under the Affordable Care Act, which is set to begin the beginning of 2014. This is the state of play. I'm sorry that I didn't get the better color scheme here. The states that are the lightest light blue are not moving forward at this time. The state, and that's 21. The states that are the next darkest light blue are moving forward, and then the dark ones are having a kind of debate about what they're going to do. This is as of June 20th. I didn't update since then. So you have, oddly enough, the same kind of relationship to the density of Medicare spending, but that's where we are. What are the challenges for the government payer? Obviously, these programs, and I'm going to come back to cost a few times in this talk, Medicare and Medicaid typically set prices for the unit of service they render. They can't fix their total expenditures. So the more providers can sort of run up the bills, the more they pay out. Prices should be high enough to assure that providers participate. So if they lower the price too much, for instance, in Medicare, primary care doctors will say, I'm not taking new Medicare patients. And that's an appreciable percentage of doctors in different states. In some states, 40% of doctors will say, I can't take any new Medicare patients. They obviously can't. So this is a challenging situation. And obviously, they have to provide. Providers will increase their services to protect their revenue stream. If the price goes down, they tend to figure out a way to do more. So what do we gain from healthcare, and how does the USA stack up? There are many, many, many possible ways to address this question. My gander through this topic is highly selective, not meant to be severely biased, but there's just many metrics you can use in looking at the U.S. healthcare system versus others, and in looking at U.S. health versus the health of other nations. So this is just a kind of overview of different ways to look at it. But let me first highlight that we clearly gain something from healthcare. And I put this because, you might think after 2 lectures on the escalating healthcare costs that this is just a monster galloping out of control. And maybe it is. But for something like heart disease, we've had a remarkable set of progress over the last 30, 50 years, really, in reducing the rate of death from myocardial infarction. And this chart is really looking at mortality in the population at large. Down at the bottom, I put a statistic that the rate of 30-day mortality after myocardial infarction is 3 to 11%, depending on the population, the sample. But all these are all different studies. 1961, the coronary care unit was developed. That's where people get shocked if they go into defibrillation, ventricular fibrillation. All these innovations in our healthcare system have been, to a great degree, delivered to a great number of people, conferring benefits. So there's something good about this system, despite its galloping costs. Now, how does U.S. stack up relative to other developed countries? And there's a host of measures. And again, I just try to choose some where we do worse, some where we do better, some where we do middle. And I don't think that's terribly misleading. Cost-related access to care problems. And survey data, and I'm talking about other developed countries, when they survey people about have you had to not get the care you thought you needed because you have an affordability problem, we tend to do badly. That's a commonly reported problem among American adults. Rapid access to a primary care provider where you need to see somebody the next day or within 2 days who's your regular care provider. We do worse than most, not all, but worse than most of the, usually these comparisons are to 11, 14, or 16 developed countries, just depending on the study I pulled. Rapidity of access to specialists. We do better than most. Not a surprise, we have a high supply of specialists, so you can get in quickly. 30-day mortality after a heart attack. That's one of the things I just emphasized. We're kind of middle of the pack among developed countries. Now, you could argue here that maybe our hospital care is superb and that the problem is that we do a little worse because something else. Maybe it is that people who've been hospitalized are less easy to hold in the system of care after their discharge. Or maybe they come, on average, an hour later to the hospital for their care to begin. So I couldn't find anything to show that's the case, but there's always room for argument about what this statistic means. Or maybe we just have a larger population of really bad hospitals, even though if our best do better than everybody else. There's always a room to sort of negotiate. Maybe we're better than middle. Maybe we're not. Hospitalization rates for uncontrolled diabetes. Compared to these other developed nations, typically things like France, Germany, et cetera, we're kind of middle of the pack. Cancer screening. We have high rates of cancer screening compared to other nations, near the top. And blood pressure control and cholesterol control, high rates. Mixed bag. So many indicators. Our position ranges widely. The U.S. does tend to identify cancer earlier. We have access to care issues, and we have more cost-related stress in our population than in most of the comparison nations. And I guess that leads to a question is, would, I guess, remedying this or would improving this care that we get confer an improvement in health? I mean, I guess if you listen to the healthcare debate, I mean, how many of you heard something like this? The U.S. spends double the amount that all the other countries in the world spend, and we still have only the 27th best life expectancy. People heard that kind of thing? There's no interactive response, but yes. I mean, So the implicit assumption is, gosh, we got a bad system, and if we just got everyone covered, we could resolve this. And there is a hint that we have a problem. This is a statistical indicator. Here is, again, a comparison to developed countries, countries which already have things like, public transportation and electricity and relatively good wages. It's 21 countries, the Organization for Economic Cooperation and Development, France, Finland, Germany, Canada, those kinds of countries, Liechtenstein, oddly enough. The U.S.'s life expectancy at birth, here for a female, was, in 1979, a little over 77 years, and we gained over the next 30 years, 25 years. But we moved in ranking down because everyone else gained more. And this is a hint of a problem. What's the problem remains to be discussed, and is probably not just our healthcare system, but just to give you a sense, things like this give you a sense that we're lagging in some reason. Anybody have any thoughts about why our females might have not gained the same life expectancy as other nations over this time period? Just speculation. I'll entertain a few.
Many of the developed nations are moving away from increasing pay as they work in advance to increasing time off and vacation. And so the quality of their life throughout their middle years, as far as having time with their family and vacation, this increase in stress is better than working.
So maybe lifelong stress differences based on time for maternity and departure. Obviously, I haven't seen a test of that, but that would be a thought. Other thoughts?
Lack of access to primary care, to establish preventative measures, kind of important that.
So that's certainly close to my heart in terms of my political point of view. Not crystal clear that that's true, because by the time these women are 60, when health care is supposed to be available, or 65, they got Medicare, so they should have primary care. So maybe, we have an obesity epidemic, and there's a lot more overweight people in the United States than in other countries. So that, too, could account for a lack of gain if we have this new health-related factor that we're acquiring a risk faster than everybody else. One more, and then I'll add a last one. Okay, on the aisle. Oh, so maybe the system that's collecting the information is better here? Do we know who's dying? I think that life expectancy is fairly rigorous. I can trust that. I think that the U.S. is pretty good at recording who's dead, although we may not be good at recording a lot of details about them. But I think for cancer and for who's alive, we're okay. One thing that should be mentioned is not going to align with my desire to expand primary care, which is that, one of the things that's causing a lot of death among women in the 1990s and early 2000s is the intensity of smoking that was taken up by American women in the 1960s and the 1970s. We smoked more in volume and more in prevalence than some of our comparator nations in that time frame. So we may be, and the National Academies of Science looked at this, they think part of what's happening is we're realizing the outcome of an epidemiologic change 20 or 30 years ago. So it was a bad healthcare system why Americans don't live as long as peers in other developed countries or haven't made the gains that others have made. In wrestling with this, I've come to realize that the window into this very broad question it really is, you craft your own window, you ask a subsidiary question, and then you draw the answer you want to draw. And this is sort of what I learned through exchanges with Dr. Huddle yesterday. So one question you could say is, look, how much of human mortality can really be explained by medical care access as opposed to genetics, social conditions, behavioral choices, and the environment? Those are pretty big things. So how much is really due to medical care access? So you could begin to see where that's going to lead. Here's a different question. How much, and the reason I'm telling you these questions is you're going to hear them in political debates, and people will not tell you what question they're using when they want to make their point. So I'm going to tell you what the background questions are so you can interpret debates we have tomorrow or in the future. How much of recent gains in life expectancy are due to medical care improvements? It's kind of a different question. So if you want to count life expectancy gains since 1960, and we've gained life expectancy roughly 8 years, there's some modeling exercises that suggest roughly half that is due to the improvements in medical care. If you want to count life expectancy gains since 40,000 BC, I'm going to argue that fire, the wheel, animal husbandry, and agriculture play a much bigger role in those gains, and that medical care is not very important. So you can frame this one up a couple of different ways. How much can we attribute the USA's lesser gains in life expectancy to our healthcare system versus other ways in which the US differs from other countries, like the obesity epidemic? So these are three slightly different questions. They all try to ask, well, how important is the healthcare going to be to fixing our mortality problem? But they all lead to slightly different directions. So if you emphasize human mortality and medical care just being a small part, tends to lead toward a view that you should promote health broadly and look for a better return on investment in behavioral and social and environmental interventions. Help kids make sure that they're safe and get good nutrition prior to their being born and in childhood. Gains in life expectancy analyses, well, you might say, look, medical care still counts a lot. Make sure everyone gets it. If you're trying to explain this divergence between us and other developed countries, I'm really paraphrasing a National Academies report. You'd say medical care access or quality is one factor among many. It all depends which particular cause of death we're talking about, which particular age group, man or women. It plays here, a difference here, but not there. Tom, you want to comment on this?
I think that's a very fair summary there.
So you just sort of wind up in a different place. You'll hear us echoing this tomorrow, I think, in the panel, given the ways it's gone in the last years. So that's where, so I've left you with no answer, but a sense of how the questions are posed. So what about health expenditures? And this is obviously a quick take on something you've studied in depth, but some facts. What do we spend money on? We may have a test question on this, so think about it. Hospital care is clearly a big chunk. Physician services and other health spending are big chunks. I think other spending includes administration, the cost of administering private health insurance, public health activity, research. Other kinds of personal health care, I think these are like dental care, eye care, medical equipment. One of the things I'll notice is prescription drugs are only 10%. When I think of the pharmaceutical industry, and I love them and I hate them, but they're like the gorillas of the healthcare politics. But they're kind of a small component of the overall national health expenditures. On whom do we spend money? You may have seen this. There is a spread, but this is a graph where on the left, what you see is the percentage of total healthcare spending on what percentage of the population that goes to. So the top 5% are targeted by 49.5% of the spending. The top 10% account for 65% of the spending. It does make sense. If you're not sick, we shouldn't be spending much money on you. If you are, we should be spending more. Yes? Would you like to suggest something maybe better?
What about our satisfaction with healthcare or our quality of life because of healthcare? Why is it just how much longer we live?
Yeah, I mean, I think you're right. In fact, I chose one thing because that's politically used a lot, but in well-done papers, what you'll see that they'll analyze disability-adjusted life years, which is a numeric way of trying to total number of years in good functioning versus years with impaired functioning. And we often stack up poorly on those two, but it does lead to a different picture than just life expectancy. And I think it's a very important issue you raise. If you want to consider this broadly, you need to consider the benefits and lack of such, but benefits often from healthcare, reducing disability. Yes?
When I was looking at the graph earlier that showed the U.S. Slight rise compared to the one question I would have is life expectancy, when presented as a number, is likely a distribution. So are those individual countries statistically significant from us? I would imagine that instead of saying 27, which is easy to say based on an average, we are likely not statistically different from many more than that. Maybe 5 or 6 or 7. You look at it as far as can we say that they are actually statistically different? I imagine we can.
I have not checked for p-values in these studies, but I will say this. Normally in studies where there's millions of data points, every difference is statistically significant, but whether it matters to you is a different issue. So you might say, look, we live to 71, or we live to 76, they live to 77. That's statistically significant, but I'm not sure it matters to me. I'm not sure I want to pivot my healthcare system on that. So statistical, maybe yes, but clinical is still worthy of public debate. Yes?
While we're still on this graph, another thing that wasn't mentioned is life expectancy is very much determined by infant mortality. And our infant mortality rate in comparison to other developed countries is
Crummy.
pretty awful.
So the way around that is to do this graph again, but look at life expectancy, assuming you survive to age 50. We'd do the same. That's no better. But if you do it, assuming you've survived to age 75, we are great. If you make it to 75 and you're an American, you are better off than all those other countries, or almost all of them. You really, but it's either because it's the hardiest possible person or because the healthcare system is really situated to add one extra year on for that person who's got the access and survived. Yes?
How much more statistics related to uninsured versus just public health issues like obesity or
I think that your sense of wanting to know that is exactly what this talk was designed to trigger. And one of the things that, and by the way, I worked on the talk because you asked that. Like I said, gosh, I got to get at this issue. If we isn't in a reference at the end, I will at least point you to we'll have Tom send it out. There's a long discourse by the National Academy of Science called Reasons for Divergence in Mortality Between the U.S. and Other Countries. And it's a qualitative exercise. They look at lots of statistics. And in the end, they try to tab through each of the potential contributors for mortality at different ages. And I'll make sure the link gets sent to you. It may even be in the talk, but I don't see it yet. And fundamentally, it was a very hard question to be able to give you a solid answer. It's like it's a little bit of this, it's a little bit of that. We're not sure exactly how much. One last one, and then I'll sort of move along.
My question was how the U.S. rank compared to countries with similar population, because comparing a population of the U.S. isn't really fair to comparing it to Luxembourg.
Yeah. That's very, very difficult because, in certain ways, we are a developed country that is fundamentally more diverse. And by diverse, that includes immigrants, and it includes the after effects of slavery, people who were brought here involuntarily, and the economic development of all of those groups in large numbers compared to other countries. I personally have not, in my mind, I have no recollection of any completely easy comparison point for that. So I think you're proper to ask, and it doesn't have the quick answer. Okay, I'm giving it one last one, then I'm going to move on.
whenever they talk about costs, are they normalized to population? Because the next closest developed country we're roughly 4 times the size.
Oh, yeah, costs are per capita. So there's a graph at the very end of the talk. I may not even show it, but it shows we're $8,000 per, but it's always per capita, and usually it's age-adjusted as well. So what's driving our healthcare cost increases? This is my overview. Tom can add, but what projected in the future? Aging population, different kinds of medical technology that make all kinds of interventions attractive, some of which are unproven in terms of their benefit, but nonetheless get paid for. How physicians respond to payer and market opportunities. If you are a hospital in Massachusetts where the health insurers are desperate to say that Mass General is in their panel, you can drive your price up. Permissive factors. The prices for care are often and typically, and I got this from Tom's lecture, invisible to patients and providers, so that limits some of the decision making or affects it in some way. And then, on the contrary side, when you think about prices, the tricky thing is once you're sick enough to be in the top 10%, it's hard to be a choosy shopper. That is, I might be able to shop around for an elective hip replacement when I'm a generally healthy 73-year-old, like my father is, and I think you should get one. But, if it's a whole bunch of stuff at once, probably you're going to say, doctor, what should I do? And at that point, trying to engage in some sort of game of searching for the perfect hospital somewhere around the country that's going to give you the best deal, it's going to feel pretty shaky. Tom, want to comment? No? Okay. We do have high prices. A couple of things. These were in the New York Times a couple months ago. Average U.S. price for each of these procedures is well in excess of the others. I can't really believe the angiogram price. I'm struggling with that. Like, I actually meant to double check if there's an error from the New York Times on the $35 angiogram price. Just can't really believe that. But the others, the point with colonoscopy, which is what they emphasize in the article, is the average price paid by insurers and Medicare together is $1,000 compared to a much lower price in Switzerland. But Medicare actually negotiates that down. They dictate it down is actually what they do. And so Medicare doesn't pay a lot more for a colonoscopy, but the private insurers do. So prices are high, and that's clearly a big factor in our cost growth. Cost growth. I just want to nuance the description. The healthcare system has rising expenditures. You may think that the rise is utterly uncontrolled in all ways. I'm going to say it's utterly uncontrolled in most ways. Medicare's growth per person in the program is generally less than private insurance expense growth per person in the program. And that's graphed out for periods of years. The darker green is Medicare, the lighter green is private health insurance in different phases of time. Usually the darker green column is lower than the lighter green one, except for one period when managed care really hit the private insurance market in the mid-90s. And they managed to enact all kinds of contracts that helped restrict care, but got a massive pushback from the American public and lots of legislative response to roll back those management techniques. And actually, if you look at 2007 to 11, you can see that the rate of growth per beneficiary has been slower than the previous period. A great deal of that is due to the economic slowdown, although Medicare is a payer which in principle you should be able to use whether you're in the middle of an economic depression or not. But some of that may be due to changes in the health system. There's a lot of debate about this. Now, that isn't meant to take away from the reality that the percentage of gross domestic product that we spend on Medicare, Medicaid, and other, this is public health expenditures, is very high and rising and projected to continue to rise. And the number of workers who are going to be paying for this with their tax dollars is, the ratio is getting increasingly disadvantageous as the baby boomers retire. So we have a crisis. I don't mean to completely put you at ease. What happens without coverage? This poll data shows that the uninsured in the U.S. are much less likely to have a regular medical doctor and much more likely to report unmet needs because of cost. This is survey data. This survey data underestimates it compared to some other surveys, but it's just one of the national survey data that's available. I want to, people talk about healthcare access. I want to put this into an example format and show how this person would be affected somewhat under the Affordable Care Act. So this is based on a person, a 39, maybe 40-year-old analyst for a nonprofit museum, actually in Chicago. She was earning roughly $39,000 and was not offered insurance. I heard about this last year. Had a lump in her neck. Visit was followed by ultrasound and biopsy done at a teaching hospital. She was told she had thyroid cancer. The hospital, however, was frustrated that she had not managed to pay for the workup that she'd already received, a few thousand, maybe several, I don't know, thousands of dollars. So they'd begun collections activity on her. So she was referred to surgery to get care for the lump in her neck, but the endocrine, and the surgeons just, the hospital surgeons won't see her. So we have collections activity on you. We can't see you for this. You're not someone we can care for. So I think that should feel uncomfortable. I hope it feels uncomfortable. It's the intention. The woman has cancer. She's got a problem. She's been told to go to this doctor. She can't. So what are her options? And this is what happens in the safety net. Because you'll hear people say everybody can get care in the end. You can go to the emergency room. So you can, and this is sort of the ways it plays out. So one thing would be to find a hospital with a charity care program, perhaps the very one that she's at, and apply. The problem is with that $39,000 income, she may not qualify, or it may not even exist, depending on whether it's at the hospital. There's probably going to be a delay while she gets processed through that charity care program, given that this is still not an emergency. It's not just she's getting a heart attack care. She could apply for Medicaid in her state. She may not qualify. There may not be a provision for $39,000 earners to get it. There would be a major delay. Medicaid will then channel her to different providers in order for her to get specialty care. So that will just fragment and discontinue what she's already initiated. And she may not be able to find a specialist who's willing to take the low Medicaid rate. She could redirect her care seeking to a county hospital for the poor if it's still open. Now there's going to be a delay because she has to get in. They're going to want her to see their primary care before they refer to a specialist. And this is, again, discontinuous and fragmented care. She could try another private provider and maybe swing in a credit card and hope they don't notice that she hasn't been paying the bill. She may not be able to find someone to see her depending on how closely they look, but it's going to harm her financial situation. She could go to the emergency room, but obviously that would be later, and it's sort of... So this is a bad situation, being in the safety net, particularly in this case in a weird way because she has an income that's appreciable. So what about insurance? She could have gone to the insurance market. Why didn't she buy a policy 3 years before that would cover these kinds of disaster situations? About 20% of uninsured people with her income situation actually do buy private insurance on the individual market. So I ran the numbers. And I kept some of them small so you don't try to read them all, but I calculated, given her taxes, what her monthly take-home pay is. I tried to put together a monthly budget for her. I assume she's paying off a student loan and that she's saving $250 a month for retirement. And I figured she's spending $23.80 out of her $27.50 a month. And I figured she's got $370 a month in disposable funds, assuming no one in her family needs her help. I went into the Chicago market on the eSurance or ehealthinsurance.com. I found an Aetna plan with it's actually a $5,000 out-of-pocket limit, not $10,000. No, let's think. It was $5,000 deductible, $5,000 out-of-pocket. Yeah, so it's $10,000 total. And that was actually affordable, given her extra money. So she could have gotten a policy. The challenge would be for her that in the year with the thyroid cancer, once she paid out her insurance premiums and the deductible and the out-of-pocket, she would have an unfunded liability for her care of about $8,200. That's a gap, given her income of $39,000 gross. That might be manageable with debt, a payment plan. I mean, a bank's not going to give you a private loan for this, but maybe family debt or bankruptcy, assuming she was insurable. But 1 in 7 people are denied insurance when they seek these policies, and that no other problems occurred, and that no one needs her help that year. So I don't think it's a great deal. But what happens if the Affordable Care Act swings into play? So I'm not going to show you all the numbers, but the difference, the model up top, I already just showed you the $8,200 unfunded liability. What if she got a silver plan on the exchange? She'll have to pay $317 a month, which is more than the $220 a month from that plan I just showed you. She'll have an out-of-pocket maximum of $6,350. She'll get this policy without underwriting. She's going to be just given it, regardless of her past history. Her likely total expenditures with thyroid cancer that year will be $10,154. Her unfunded liability still is appreciable at $5,714. So she still has a bit of a problem. So you can argue about whether, for this woman, the Affordable Care Act rescues her or not. Now, she will be covered if she decides to have a child. She'll have maternity care on this. She won't on the other one. And her past medical history won't be held against her. In terms of financial help with income, which income class gets the least help under the Affordable Care Act? By the way, there will be an excellent lecture tomorrow that covers a lot about what the Affordable Care Act does, as well as considerable discussion. So if you're feeling, I don't know this stuff, you're going to get it. So the plurality here, we're right. It's this group that is getting some help, but is over 300% of federal poverty level, like this woman was in my example. Financial help, for people up to 138%, they get Medicaid, which I guess I would call financial help. But if you didn't think of it as financial help, you might have answered that one. And then there's really quite a bit of help if you're in those middle categories, because you're protected in terms of the overall out-of-pocket expenses that you would undertake, as well as assistance in paying the premium. If there's no insurance, who pays? It's hard to calculate these things, but I cite a report. If you download slides, you can actually link to it. In 2008, the estimate was the uninsured obtained $84 billion worth of care. You're going to see that the price of helping the uninsured is higher than that. But they pay $30 billion out of pocket, and then there's $54 billion, which is kind of uncompensated. How does that get handled? Well, a smaller portion of it comes from other kinds of public appropriations to cover the basis for the hospital private foundations and charity and other sort of, and then finally $27.8 billion of it is sort of the hospital shifts costs around to deal with this liability on their books. You can get care in the emergency room. I think you might know this, but just realize the law that requires emergency rooms to treat and stabilize doesn't mean that the care is free. And the hospitals will give something out called uncompensated care, but that combines whatever they deem charity and what they deem bad debt, that the money they thought they were supposed to be paid that wasn't paid. Question? So I don't know the accounting rules. I think that, so obviously charity care contributes to tax-free status for some hospitals, but the question is if you have uncollectibles, can you reduce that from your income, particularly for a for-profit institution? I guess it's only worth a write-off if you have to pay for profit. It would seem like they should, but the truth is I don't know for sure. Anybody here work in the tax industry? Okay. Anybody else? Does getting coverage make it better? This is a return back to that other issue, but this is a little different. This is not going to account for America. What happens when people get Medicaid? Does it change things? I'll show 2 studies. There are many, many more. This is a natural experiment. A study published in New England Journal of Medicine looked at 3 states that did expand Medicaid over, in the last 5 years to 4 states nearby that did not, comparing New York to Pennsylvania, Maine to New Hampshire, Arizona to Nevada and New Mexico. And the uninsured status among the poor in those states did drop by 4.5%. Not a lot, but some. And mortality dropped in the Medicaid expanding states over those years. So this is, here's several years of follow-up, 4 or 5 years. It seems like the expansion states already had a somewhat lower mortality among the non-elderly adults, and then they diverged from the control states over this 9-year period, and that trend seems to get bigger in the years after the Medicaid expansion. This is observational data. We didn't randomly assign the states, obviously. There are limitations to the study which were acknowledged by the authors. There was a general rise in health care coverage in all the states, which confuses the analysis. Also, the elderly people also had reduced mortality in the expansion states. And that has nothing to do with Medicaid. So it raises the question of whether in this study there was something else driving down mortality in poor people in those states that wasn't the Medicaid expansion, since the elderly got it too. Yes? It all depends on what the editors say. It's often the case that in a perspective article or a special article in New England Journal that you won't see them, but if you went to a more subspecialty journal, they would insist on the error bars. These are model-derived estimates, and there are errors. There are standard errors for all of these. No. But the deaths is a computed average death rate across those states. I'm sure it's pretty complicated analysis, but it is, deaths among people. Another view of this is the Oregon Health Experiment, and then we'll be done. 3 minutes, that's good. Oregon randomly offered Medicaid to impoverished adults in Oregon with 24-month follow-up of people who got it and people who weren't offered it. And the average duration of Medicaid in a 2-year study was that they got it for 18 months. And there was an increase in health care spending on the people who got it by about $1,200. And there are a number of negative findings that were published this year from that study. And the readings include some commentary on this. There were not differences on a whole on cholesterol, blood pressure, or blood sugar between the controls and the intervention group. There was a reduction in depression prevalence, also increase in depression treatment in the people who got Medicaid. People had a better perception of their health being the same or better if they were in the Medicaid group. They had more testing for breast cancer, more testing for diabetes. These are more detailed than I think makes sense given the time. I'll just highlight a couple. The diagnosis of diabetes was made more commonly in the people in the Medicaid group. That's the 3rd row down in gray. So diagnosis and use of a medication for it was more common. But actual control of blood sugar was not. Screening, depression was less common at the end of follow-up in the Medicaid-covered people, and mammograms are more common. What can we say about this? 18 months of Medicaid doesn't cause major health change for middle-aged poor people. It prevents financial problems. That was a finding. There's a lot less financial trouble due to health care. And for some conditions, a relevant screening or treatment was more likely to take place, but not always. So for a lot of people looked at this as a more negative than positive study. So overall conclusions, we have a complex system. Insurance lack results in burdens for people, financial burdens at least, and often I think health burdens. You can judge based on what you've seen. The U.S. health disadvantage is likely partly related to its health system. You can put an error bar on the word likely partly. And the Affordable Care Act will have impacts on Medicaid and insurance purchase, and we will continue that discussion tomorrow. Tom, should we not take questions and let people get a break, or?
Let's formally adjourn, and please come down and ask out any questions.
Okay. These are always fun to give in the end.